Lower urinary tract symptoms may be divided into voiding, storage, or a combination of both. Notably, not all men with BPH develop LUTS. Poor bladder contractility may contribute to difficulty voiding, and this can be neurogenic or age-related. Voiding symptoms are hesitancy, poor stream, intermittent flow, incomplete emptying, post-void dribbling, and overflow incontinence. Storage symptoms are frequency, nocturia, urgency, and urge incontinence. Complex symptoms are hematuria, recurrent UTI, acute or chronic urinary retention, and urinary incontinence. Causes of storage symptoms are UTI, bladder calculi, urothelial carcinoma, and overactive bladder. Causes of voiding symptoms are BPH, bladder neck stenosis, urethral stricture, and poor detrusor contractility. International Prostate Symptom Score. The International Prostate Symptom Score provides a validated method for assessment of symptoms and quality of life. The IPSS is useful in quantifying the initial symptoms and response to treatment. The impact of LUTS on quality of life is highly variable, and in the absence of medical indications, therapy is not needed if bother scores remain low. Assessment. A comprehensive history is essential and should include questions about the comorbidities and medications that can affect LUTS. For example, diuretics, diabetes, heart failure, and sleep apnea can all contribute to nocturia. Physical examination should include the genitourinary system to exclude a palpable bladder, phimosis or meatal stenosis. Digital rectal examination is useful to estimate prostate size and to exclude obvious abnormalities suggestive of malignancy. Most men present with a combination of voiding and storage symptoms. Patients with complex symptoms need further investigation and early referral for specialist care. A urinalysis and culture should be performed in all patients to exclude a UTI and the presence of microscopic hematuria. The IPSS can then be used to stratify older men with LUTS. Patients with high bother scores warrant early referral for specialist care, and those with lower IPSS, or low bother scores, in the absence of the complicated features outlined, can be managed in the primary care setting. If there is a suspicion of hydronephrosis, bladder stones, or chronic urinary retention, transabdominal ultrasound is necessary. After appropriate counseling, prostate-specific antigen may also be checked to assess the risk of prostate cancer. In the specialist setting, uroflowmetry and bladder scanning for post-void residual volume may be helpful to further evaluate LUTS. Both may indicate bladder dysfunction or significant bladder outlet obstruction. Watchful waiting. Men without bothersome symptoms are suitable for watchful waiting and monitoring, particularly as the side effects of some of the treatments may outweigh the benefits. Patients with mild storage symptoms should undergo behavioral modification. Overactive bladder symptoms and nocturia may be alleviated by restriction of caffeine, alcohol, and evening fluid intake. Diuretic medications should be taken in the morning. If void volumes are small, bladder training assists to suppress urge and increase time between voids to 2 to 3 hours. Regular monitoring with history, physical examination, and the IPSS assess treatment response and changing symptoms. Increasing symptoms or bother scores are reasonable indications to consider medical therapy. Medical therapy. Surgical treatment is more effective, but medical therapy may provide adequate symptom relief with fewer and less serious adverse events, and is a useful adjunct to behavioral modification and bladder training. Medical therapy is easily commenced in the primary care setting when the diagnosis is clear. Failure of medical therapy or progression of symptoms while on medical therapy would be an indication for specialist referral for consideration of other options. Alpha blockers. Alpha blockers are used to treat voiding symptoms and may improve urinary flow. Although ineffective in prostatic size reduction, they block prostatic alpha-1 adrenoreceptors to cause prostatic smooth muscle and bladder neck relaxation. They can also have peripheral and central nervous system effects. Efficacy is similar between selective and non-selective medications and is not affected by IPSS or prostate size. There may be an improvement in IPSS by up to 40%. There is no reduction in the long-term risk of urinary retention. Selective alpha blockers may have fewer systemic side effects. Antimuscarinic therapy. Antimuscarinic drugs treat storage symptoms. Acetylcholine acts on muscarinic receptors and stimulates detrusor contractions via the M3 receptor subtype. M3 selective drugs may have fewer anticholinergic side effects than non-selectives. Antimuscarinic drugs are contraindicated with high PVRs as there is a risk of acute urinary retention. Antimuscarinics may impair cognitive function and should be used cautiously in the elderly. 5-alpha reductase inhibitors. 5-alpha reductase inhibitors, which are used to treat voiding symptoms, inhibit the enzyme 5-alpha reductase to block the conversion of testosterone into the more active form, dihydrotestosterone. 5-alpha reductase inhibitors induce prostatic epithelial cell apoptosis, thereby reducing prostate size by up to 25% over a 6 to 12-month period. The IPSS may improve by 30%. Combination therapies. Combination therapy using an alpha blocker with a 5-alpha reductase inhibitor is more effective than monotherapy at reducing disease and symptom progression. Surgical treatments. Absolute indications for surgical treatment include refractory urinary retention, bladder stones, recurrent infections or persistent hematuria. Patients may also opt for surgical treatment over medical therapy. Transurethral resection of the prostate remains the gold standard treatment. In summary, LUTS may be divided into voiding symptoms or storage symptoms, or a combination of the two. Most bladder outflow obstruction is caused by benign prostatic enlargement. The IPSS is beneficial in assessing symptoms as well as the response to treatment. Absolute indications for referral to a urologist are presence of complex symptoms, failure of medical therapy, progression of LUTS or inability to tolerate medical therapy are indications for referral to a urologist.
Audio Jungle. Audio Jungle.